Assalamu alaikum wa rahmatullah. Good morning, Mr. Chairman, ladies and gentlemen. It's a great honor for me to be here today with you. I will present three quick cases of chronic stable angina with different clinical scenarios. Case number one, this is a 60 years old male, smoker, hypertensive. He presented to us in 2006 with 3 months history of atypical chest pain. ECG and echo was normal, ETT was non-conclusive, so he went for coronary angiography. As you can see, there is normal left main, proximal circle non-significant, proximal ramus significant lesion, proximal LAD long angiographically significant. Again, here at the LAD lesion, and RCA show proximal borderline lesion. So in conclusion, this patient have 3-vessel disease, stable angina, normal LV. Options that we have, multi-vessel BCI, cabbage, or medical treatment. But we prefer to go for FFR. We did FFR for all came to be negative. LAD, ramus, and RCA, all was negative. So revascularization was deferred at that time, and he was started on medical treatment. He did well on medical treatment for 8 years until he presented in 2014 with 1 month history of typical anginal pain. ECG and echo was still normal. Coronary angiography was repeated. As you can see, nearly the picture is the same, apart from some progression in the proximal circle, we will see later, and increased decalcification in the LAD. Here is the new circle lesion. And RCA is exactly the same. So again, we went for FFR. The new lesion in the circle is negative. The lesion in the ramus is still negative, but the LAD became positive. So we went for BCI to LAD using 1 absorbed stent distal and 1 metal stent proximal. And he is still in follow-up with us in the clinic for around 1 year now, post-BCI, doing fine with no more symptoms. This patient clearly showed that FFR gave him 8 years of metal-free, event-free survival. Second patient is also a 60 years old male, smoker, hypertensive. He presented in 2004 with 3 months history of typical anginal pain. Echo showed moderate aortic stenosis. ETT was positive at low workload. He had more than 1 millimeter ST depression in infralateral leads in less than 3 minutes of Bruce protocol. Coronary angio was done. I could not retrieve the CD, but I had the report. Totally occluded mid-LAD, significant ostial first diagonal, proximal OM1, totally occluded circ, and no significant lesion in RCA. We offered him cabbage plus aortic valve replacement, but he refused. So we started him on medical treatment. When he became asymptomatic, we repeated the ETT. It became negative this time. He did well over the next 9 years until he presented in 2013 with syncopal attack. Echo showed progression of aortic stenosis to severe. Again, we offered him cabbage plus aortic valve replacement, and the coronary angio was repeated. This is his coronary angio, no much difference from the report that we saw, apart from progression in the ostial LAD. And the new lesion in the mid-BDA. This patient, I think it is a classic carriage patient. He had 3-vessel disease, chronic stable angina. ETT at the beginning was highly positive. Then with medical treatment became negative. And this gave him 9 years of event-free survival on medical treatment. Third case is a 53 years old male, smoker, diabetic, hypertensive. He presented in 2010 to another hospital with 6 months history of typical anginal pain. ETT from there reported as positive, and he was referred to us for CAS. As you can see, small diabetic vessels with normal left main, small circ, and mid-segment lesion in LAD. Here is the LAD lesion and the collaterals to RCA. RCA is totally occluded at mid-segment with some bridging collaterals, and again, it is a small vessel. So in conclusion, these patients have chronic stable angina, normal LV, 2-vessel disease not including proximal LAD. So after hard team discussion, we decided to put him on medical treatment. After 3 months of medical treatment, he lost follow-up and he stopped all his medications. He presented to us in 2012 after nearly 2 years with non-STEMI complicated by cardiogenic shock and drop in ejection fraction to 25%. Coronary angio was repeated. As you can see, there is severe progression in the LAD with proximal tight lesion and diffusely diseased mid to distal LAD. Circ is the same, RCA was still the same. I think this patient present one of the critiques to the COURAGE trial, that patient adherence to optimal medical treatment is unrealistic in the real world. I will end up here by this question to the next speaker, Dr. Ferrari. Do you think that revascularization, if done to this patient in 2010, would it change his prognosis? Thank you.